So we're going to talk about the three major classes of cardiomyopathies here, and some principles that pertain to all of them are that they're disease processes that affect the myocardium of the heart. So the myocardium is the contractile muscle cells of the heart. This is what allows the heart to pump. Now, the myocardium also serves another purpose in that they make up the thickest wall of the heart, and so if they're hypertrophied or if they're dilated, it's going to affect the actual volume of potential blood that can fill in the left ventricle or in the left atrium, for instance. So think of the myocardium primarily, yes, it is the contractile force of the heart, but it also is the walls of the heart. So when the myocardium is damaged, it impairs the heart's ability to fill or pump properly, and that leads to retention of blood in the cardiopulmonary circuit. So because blood is retained in the cardiopulmonary circuit, blood can get backed up, pulmonary pressure can get increased, and that can lead to the congestive heart failure symptoms that we see so frequently in cardiac diseases, like shortness of breath and dyspnea and orthopnea and so forth. So that's possible in all cardiomyopathies. We'll see it more so in some than in others, though. Now, when you are feeling that the possibility is cardiomyopathy, excluding any kind of an emergency situation that's present, the best way to diagnose a cardiomyopathy, the most efficient way, the best next step is going to be echocardiography. Technically, the most accurate test for cardiomyopathy is a biopsy, but we tend to not use that. So the best test is a cardiomyopathy. While you're diagnosing cardiomyopathy, definitely keep an eye out for concomitant AFib. So anytime that you're having changes in the geography and the layout of the ventricles and the atria, and that happens frequently in the cardiomyopathies, as the walls grow, you need to keep an eye out for any kind of electromechanical disturbance. So we always want to have EKGs frequently on patients with cardiomyopathies. It's not going to diagnose the cardiomyopathy itself, but it will help us see if there's any AFib. If there's AFib, then we have to treat that with digoxin and warfarin. The digoxin because it's an antiarrhythmic, and the warfarin because it is an anticoagulant. And patients with AFib are at risk of clots and throwing them up to the carotid artery and resulting in a stroke. So make sure that you have EKGs on any patient who have cardiomyopathies. But the best diagnostic test is echocardiography. So all these principles pertain to all the cardiomyopathies. Let's go into some individual cardiomyopathies in detail. So these are the four we're going to talk about: hypertrophic cardiomyopathy, and this is the non-obstructive type; hypertrophic obstructive cardiomyopathy; dilated cardiomyopathy; and restrictive cardiomyopathy. So first off, we'll talk about the hypertrophic cardiomyopathy, the non-obstructive type. As I mentioned, there is also an obstructive type, which will require a different approach of treatment. The cause of hypertrophic cardiomyopathy there can either be a cause that's identified, or it can be idiopathic. When there is a cause, it tends to be chronic untreated hypertension. But like I said, it can be an idiopathic hypertrophic cardiomyopathy. You tend to see that more in young patients. So what happens in hypertrophic cardiomyopathy is that we get a thickening, an asymmetrical thickening of the heart walls. And because the heart walls get thickened inwardly, the lumen of the left ventricle, let's say for instance, is going to get smaller because the walls get thicker. So as the walls get thicker, the lumen gets smaller. And because the lumen gets smaller, it doesn't mean that the heart can't contract properly, but it does mean that the left ventricle, where we're supposed to get the blood pumping out to our body, will not be able to hold as much blood because it's got a smaller volume to work with. So that can cause a problem in the cardiac output, and that tends to be where our symptoms come from in cardiomyopathy. It's because the left ventricle can't hold as much blood. So there's no problem with contraction. The problem is with filling. So like I said, the most common cause is hypertension. This is very analogous to diastolic heart failure. Remember that diastolic congestive heart failure is simply the heart trying to pump against such a high pressure gradient that the heart has to hypertrophy in order to pump enough blood out that gradient. So hypertrophic cardiomyopathy, though, could be an idiopathic cause because you may have a normal blood pressure, but this could still develop. And that will particularly be in young patients who don't have a history of hypertension. And it can also happen in older patients too who don't have a history of hypertension. But when the patient has a history of hypertension, hypertrophic cardiomyopathy is a complication of that. Now, the most common presenting symptoms, the most common reason patients come into the ED with hypertrophic cardiomyopathy is syncope. Now, syncope can be from a lot of different causes. Hypertrophic cardiomyopathy is not the most common cause, but syncope is the most common reason patients come in with hypertrophic cardiomyopathy. Why would hypertrophic cardiomyopathy cause you to have syncope? Well, remember, the luminal volume of the left ventricle is so small due to the thickened walls that now you can't get enough blood out through the aortic valve and into the systemic circulation. And so once you hit a critical point, you may not be able to get enough perfusion up to your brain, enough oxygenation into your brain, and that can cause syncope. That might cause you to get weak and to fall down or to lose consciousness. And so you can imagine that as this gets worse and worse and worse, and the left ventricular volume decreases and decreases and decreases, the cardiac output is going to decrease and decrease. And when our cardiac output is small, that can cause syncope. Other symptoms can include angina, palpitations, and dizziness. So congestive heart failure symptoms tend to be less pronounced, and they're more common in hypertrophic cardiomyopathy, or advanced hypertrophic cardiomyopathy. So in the early stages of this disease, you're not going to see pulmonary edema, rales, wheezing, bronchi, heaviness of the chest. You're not going to see that in early hypertrophic cardiomyopathy. You'll see syncope and angina and palpitations and dizziness beforehand. Of course, as this gets progressed and that luminal volume in the left ventricle gets really small, now your blood is going to get backed up, and yes, you will have referral back to the pulmonary veins, and you will get the pulmonary capillaries, and you will get pulmonary edema, and hence you'll get congestive heart failure symptoms. But that doesn't happen early on. Another thing I want to point to is angina. Why do you get angina in hypertrophic cardiomyopathy? What's wrong? What causes angina? Angina is caused usually from coronary artery disease. But what angina really is it's a lack of oxygen to the myocardial tissue. When you have hypertrophic cardiomyopathy, you get less blood going to the aorta. Well, where do the coronary arteries come off from? They come right off from the aorta, right off from the base of the aorta. So if you're not getting enough blood pumping out your left ventricle and into your aorta, you're not going to have enough blood going into your coronary arteries, and that can cause angina. But after all this I've said, what I want you to remember most is that the number one cause of hypertrophic cardiomyopathy, if we do know a cause, is hypertension, chronic hypertension. And the most common reason patients come in is with syncope. So now let's talk about the obstructive variant of hypertrophic cardiomyopathy, and I'm going to refer to it as HOCM, hypertrophic obstructive cardiomyopathy. And similar to hypertrophic cardiomyopathy, this is also a thickening of the ventricular walls. So you got the same thing here going on. But in the case of hypertrophic obstructive cardiomyopathy, what makes it obstructive is that the intraventricular septum, which also thickens in regular hypertrophic cardiomyopathy, has thickened so much that you're actually getting a blockage of the outflow from the left ventricle. So you're blocking the aortic valve. And when you block the aortic valve, you're not going to be able to get blood moving out through the left ventricle and into the aorta. So like it says here, part of the hypertrophied intraventricular septum is blocking the path through the aortic valve. And so remember what the aortic valve does when it's stenosed. It causes a murmur. And that murmur just comes from blood kind of squeezing through that thin aortic valve. And that murmur is a systolic crescendo-decrescendo murmur because it happens during systole when blood is moving through the aortic valve. Now, what do you get when you have a hypertrophied intraventricular septum? essentially you're simulating aortic stenosis. You're blocking blood from going through the aortic valve, just like aortic stenosis. So you're going to have a murmur that's similar to aortic stenosis. It's a systolic crescendo decrescendo murmur. And where is it going to be heard? Like any aortic murmur, it's going to be heard best at the left upper sternal border. I'm sorry, the right upper sternal border. It's going to be heard best at the right upper sternal border. So remember our mnemonic. A is the right upper sternal border, P is the left upper sternal border, T is the right lower sternal border, and M is the apex. A, P, T, M. All physicians take money. So this murmur will be heard best at the right upper sternal border. Even though the aorta is on the left side of the heart, it's heard best at the right upper sternal border. This is a typo here. Okay, so HOCM, in addition to hypertrophic cardiomyopathy, non-obstructive type, also most commonly presents as syncope. But this, unlike hypertrophic cardiomyopathy, can also present as chest pain on exertion or sudden death. And this stereotypically presents in a young person, because you have this early on. A lot of hypertrophic obstructive cardiomyopathy is genetic, and it's linked towards chromosome 14, I believe. And so this is common in young children. So we're going to talk about now why HOCM is worsened with anything that reduces the left ventricular volume. So why does HOCM get worsened with, and when I say worsened, I mean it can create worse clinical scenarios, and the murmur would be could be possibly louder. Well, let's look at this heart. Both of these hearts, we're going to assume they don't look exactly the same, but that's because my artistry isn't perfect. We're going to assume they're the same heart. And so the thin white lines are the cardiac. This is a coronal view of the heart. So you're looking at it straight on, anterior, posterior. And what you have here is, with the thin red lines, is the normal heart walls. Here's your interventricular septum, here's your left ventricular wall, here's your right ventricular wall. These thick red lines are the hypertrophied wall. So this is the hydrated heart. When you're hydrated, your volume is higher, right? And so when your volume is higher, you're going to have more blood flowing through your heart. And that's a good thing in the case of having a hypertrophied septum, because what the hypertrophied septum does by nature is it blocks the outflow from the left ventricle to the aorta. So the more fluid you have more fluid to push that piece of the septum back where it should be, and so it doesn't block the outflow. Now when you're dehydrated, that septum makes up more of the area of the aortic valve than it normally would, because you have less fluid to push it back. And so anything that reduces fluid volume, anything that reduces left ventricular volume, anything that reduces left ventricular filling, so an increase in heart rate, for instance, that's going to increase the obstruction at the aortic valve. And so therefore, you're going to have more obstruction and you're going to have more symptoms. This is why, if you remember back to the valvular disease slides, this is why the Valsalva maneuver makes the HOCM murmur, that aortic stenosis murmur, it makes it louder. Why does it make it louder? Because when you do Valsalva, you reduce the blood flow to the heart. And as you reduce the blood flow to the heart, you're increasing the obstruction. And so the murmur, that aortic stenotic murmur, which is a systolic crescendo decrescendo murmur, is going to be louder. We contrast this to aortic stenosis. When we have just plain aortic stenosis, when the problem is in the valve itself, when you have more fluid going through, you're not going to hear the murmur as much, because you have more blood going through, and it's the stenosis, the murmur is going to be what's the word? Is going to be drowned out by the actual blood flow. So an aortic stenosis murmur, a systolic ejection crescendo decrescendo murmur that's worsened with Valsalva, that's HOCM. Okay, so what would the murmur be? Systolic or diastolic? It's systolic decrescendo crescendo murmur. Where would you best hear this murmur? And you would best hear this murmur at the right upper costal margin, like any aortic murmur. And would this worsen or improve with Valsalva? By worsen, I mean the aortic, the murmur gets louder, and by improve, I mean the murmur gets quieter. We say worsen because the patient's outcome could worsen. And the answer is worsens with Valsalva. Okay, so remember we said that anything that reduces the left ventricular volume is going to worsen the symptoms of HOCM. So we want to talk about what are the things that reduce the left ventricular volume, because anything that does, we want to stay away from. So anything that reduces volume, so anything that reduces the preload or reduces the afterload, is going to reduce the left ventricular volume. So what reduces the preload? What reduces the amount of blood going into the heart? Well, hypovolemia, simply because we have less blood going into the heart. Tachycardia, because we don't have as long of ventricular filling, so we're not going to get as much blood into the heart. Valsalva, also that makes sense because we're constricting the body musculature and reducing flow from the inferior vena cava. And then arrhythmia, because you're having dysrhythmic pumping from the atria to the ventricle. So we want to avoid, in patients with HOCM, we want to avoid hypovolemia, we want to avoid tachycardia, we want to avoid Valsalva, and we want to avoid arrhythmia. So keep hydrated, keep your blood pressure in the normal, or keep your heart rate in the normal range. I guess stay away from hard work that might make you grunt, and arrhythmia, meaning we want to spot out any arrhythmias in these patients and treat them accordingly. As far as keeping afterload reduction, so we want to reduce afterload reduction. So what increases what causes the afterload to be reduced? So afterload can be reduced by anything that reduces the systemic pressure, reduces your blood pressure, because that's going to cause more blood to leave the left ventricle, and it can be caused by anything that causes the heart to pump harder. So the heart pumps harder with positive inotropes, so we want to stay away from those because that's going to reduce the left ventricular volume. We want to stay away from beta agonists, not beta antagonists, not beta blockers, beta agonists, because they'll increase the heart rate. We want to stay away from nitrates and ACE inhibitors because they reduce the systemic volume. And when you reduce the systemic volume, you're going to increase your ejection fraction and increase your cardiac output. And that's going to decrease the volume left in your left ventricle. So the goal of all of this is to keep some blood in the left ventricle, keep that left ventricular volume up so it keeps that septum out of the way. So what do hypertrophic and HOCM have in common? So in common, both exertional dyspnea, shortness of breath, chest pain, and palpitations are common. Also in common, the most common cause of presentation is syncope. In both of them, you're going to hear an S4 heart sound, and that makes sense because the S4 heart sound is due to hypertrophic myocardium. They're both caused by hypertrophy of the myocardium, of course, and they can both be genetic. Now, in contrast, HOCM will have a systolic crescendo-decrescendo murmur, and that's because of the outflow obstruction. You don't have outflow obstruction in hypertrophic cardiomyopathy. And HOCM can cause sudden death. Hypertrophic cardiomyopathy can cause death. It can contribute to death, but it doesn't cause sudden death. Okay, so the diagnosis in any patient you might suspect hypertrophic or hypertrophic obstructive cardiomyopathy is going to be the same means. So you're going to get an echocardiography, and that's going to help you differentiate right there. In HOCM, you'll see the outflow blockage. In regular non-obstructive hypertrophic cardiomyopathy, you won't. So the echocardiography in both will show asymmetric wall thinning. In HOCM, you'll see an outflow obstruction. The treatment is going to be the same. What we want to do in both of these is we want to increase ventricular filling time, because what's the problematic in both of these is that our ventricles aren't filling enough because the space in our ventricles has been decreased. So beta blockers are good because they reduce the heart rate and they increase the time in diastole. And so what that means, in other words, is it increases the time that our ventricles are being filled up. And that's going to help us both in hypertrophic cardiomyopathy, where we want to increase our cardiac output, and in hypertrophic obstructive cardiomyopathy, where we not only want to increase our cardiac output, but we want to reduce the obstruction. So beta blockers are your drug of choice in hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy. Calcium channel blockers can also be used instead of beta blockers, but it's not our drug of choice. You can also use disopyramide and amiodarone, but that's probably not going to show up on the USMLE. That's more of a second-line treatment. So no beta blockers for hypertrophic cardiomyopathy. I'm getting my letters mixed up here. And hypertrophic obstructive cardiomyopathy. Any hypertrophic myopathy, you're going to use beta blockers. Particularly for the HOCM folks, they're going to want to stay hydrated, avoid strenuous activity, avoid any drug that may reduce LV volume, and all of this is designed to keep that LV volume up so we reduce obstruction. Surgery will be needed in refractive cases, and the surgery that we will use is catheter septal ablation, which will usually uses alcohol, and it thins out the intraventricular septum. That's more for the HOCM cases. And then myocardectomy, which is a surgical removal of the myocardium. That's part of the myocardium. And these patients will need prophylactic antibiotics. So with dilated cardiomyopathy, essentially we have the total opposite of hypertrophic cardiomyopathy. Here the heart can pump, here the heart can fill. It can fill perfectly fine. It might even fill too much, but the heart can't pump properly. And so this is very analogous to what we talk about as systolic congestive heart failure, where the heart can relax, but the big problem is pumping that blood out to the systemic circulation or to the pulmonary circulation. And so just like in systolic heart failure, the most common cause is ischemia. Now, other things can cause this dilated cardiomyopathy too. The heart to be able to fill properly, even fill too much, but not able to pump. Alcoholism is another prominent cause. The number one cause is ischemia, but alcoholism, chronic alcoholism, is another prominent cause of dilated cardiomyopathy. Another cause includes pregnancy, and I'm not talking about just getting pregnant the first month. I'm talking about the weeks leading up to the delivery and the weeks in the postpartum period. Certain toxins can cause dilated cardiomyopathy. The things that come to mind are the heavy metals like lead and cobalt, and certain toxins like arsenic. And then certain medications can cause dilated cardiomyopathy. These aren't medications that are regularly prescribed, but perhaps like chemotherapeutics like vincristine. And other vinca alkaloids, I believe, can cause DCM. So now, because dilated cardiomyopathy affects more, the symptoms are going to affect more of the left and right side. Remember, hypertrophic cardiomyopathy, the problem was getting blood out. So that's going to be mostly problems as far as left ventricle and systemic symptoms. So we're talking about dyspnea, shortness of breath, fatigue, syncope is number one. But here, because we have right-sided dilated cardiomyopathy, it's not just left-sided per se. We're going to have right-sided signs as well. So in addition to syncope and possibly some CHF-like symptoms, because the right side is having difficulty pumping too, you're going to have systemic symptoms in your venous system leading up to the right side of the heart. So your right side can't pump out to the lungs, so your right side is going to be malfunctional. Pressure is going to build up in your systemic venous system. And so that can cause fluid to move out of your veins and into your tissue. That's peripheral edema. It can cause fluid to move out of your veins and into your peritoneum. That's increased abdominal girth and ascites. It can move into the liver. It can move into the spleen. And so you can have hepatosplenomegaly. And so having both left and right-sided symptoms will point you more towards dilated cardiomyopathy, whereas having more left-sided symptoms, particularly syncope, is going to point you more towards hypertrophic cardiomyopathy. So, okay, this is something. So the history in these patients are going to be chronic ischemia. That's the number one cause, is that these patients have taken multiple hits, maybe small hits, maybe subclinical hits, but they fit the ischemic profile. They have coronary artery disease. Another common way for you to get this on the USMLE is the alcoholic patient. Maybe doesn't have coronary artery disease, but they have a long history of severe alcoholism. You could see this come up in an OBGYN patient who's pregnant, and in maybe 4 weeks prior to term or 4 weeks after term. You can see this in a patient that is exposed to heavy metals. You can see this in a patient that's exposed to arsenic. You can see this in a patient that's getting chemotherapy. Now, dilated cardiomyopathy is very analogous to systolic heart failure, and that's a good way to think about it when you think about what are going to be the symptoms and what are going to be the physical findings. The physical findings with systolic heart failure, with inability of the left ventricle to contract, are going to be an S3 sound, sorry. An S3 sound, and that's simply because you have blood left over in your left ventricle after systole. Because you have such a low ejection fraction, a lot of that blood is going to be left over, and when blood comes in from the left atrium during systole, you're going to get an S3 heart sound. You're also going to have rales, rhonchi, and wheezes. That's due to increased pulmonary pressure. And then because we have increased right pressure, because of an inability to pump out the right heart, we're going to have increased venous pressure. So edema, jugular venous distension, and an elevated respiratory rate. And that actually has more to do with the increased pulmonary pressure because we're not getting enough oxygen across. So those are some things to look for on physical exam. None of these are diagnostic for dilated cardiomyopathy. Certainly you could have an S3 sound in a patient who has who simply has a dilated or systolic congestive heart failure, rather. You could have it in a patient that has a ventricular shunt. But you put these together, put together the history, and then you kind of know your presumptive diagnosis. So the diagnostic test, the best test for diagnosing dilated cardiomyopathy, is going to be an echocardiogram. It's quick and it's easy. And what it will show is dilated walls. It's also good to get an EKG to look for AFib, because dilated cardiomyopathy can affect the atria, and it can cause the atria to become enlarged too. Remember, when the heart gets enlarged, the conduction system doesn't enlarge with it. So whenever the heart gets enlarged, you put yourself at risk for arrhythmia. And it's also good to get a chest x-ray in these patients to assess the degree of the pulmonary edema. We're going to treat this the exact same way that we treat systolic congestive heart failure. And remember the way we treat systolic congestive heart failure. In the emergency case, we're going to give them diuretics to get the water off their lungs so they can at least breathe better and get their oxygenation up. And then in the long term, we want to do things that are going to encourage blood to move out of the heart. So even though we can't increase the stroke volume per se, we can help promote stroke volume by reducing the systemic blood pressure and hence increasing the amount of blood flow when the heart does try to pump. And so ACE inhibitors, beta blockers, and spironolactone are all proper management. Okay, restrictive cardiomyopathy kind of falls out of the category of the other two simply because What it is a rigidity of the myocardium. So this is actually a disease of the myocardium rather than a malfunction. So what we have in restrictive cardiomyopathy is actual histolic damage, and it can be due to infiltration of many different, I guess you could call them invaders. Malignancy, it can be due to malignant cells moving to the myocardium, or it can be due to direct physical ionizing damage. It can also be idiopathic. So in restrictive cardiomyopathy, because it's actually a disease of the myocardium itself, the myocardium isn't going to want to do much at all. So you're going to have difficulty filling and contracting both. So what distinguishes restrictive cardiomyopathy is that you're going to have decreased right atrial compliance. Normally, you should never have that. The right atrium is the first place that the blood goes. So unless there's something wrong with the heart tissue itself, rather than pressure somewhere else, or rather than having ischemia, there really should very rarely, if never, be anything wrong with the right atrium. And so when you have a decreased right atrial compliance, that is a sign that you've got something seriously wrong with your myocardium in your right atrium. And that tends to be a sign of restrictive cardiomyopathy. So what's going to happen when you have reduced right atrial compliance? Blood is not going to be able to flow into the right atrium as readily as it would if there were no disease. Now, when right atrial compliance is low, blood cannot move down your jugular vein in through to your superior vena cava and into your right atrium. Because of that, your jugular venous pressure is going to be increased. You're also going to have prominent right-sided heart failure symptoms because all of the blood is supposed to go to that right atrium. If the right atrium is diseased, right-sided heart failure signs are going to be prominent. Blood from your venous system have nowhere to go. And so this is going to share clinical features with both hypertrophic cardiomyopathy because you do have damage on your left heart, and dilated cardiomyopathy because you have some right-sided symptoms too that you don't necessarily see in hypertrophic cardiomyopathy. But you will see that this is a very unique clinical symptom or syndrome between the two. So let's talk about the causes of restrictive cardiomyopathy. Most commonly, restrictive cardiomyopathy is idiopathic, but when we do have a cause, it is sarcoidosis in the US. That's number one. And that's just infiltration. Amyloidosis can be another cause, and there's many different types of amyloidosis, and that goes beyond the spectrum of this talk. Hemochromatosis, which is elevated iron that infiltrates tissue, not just the heart. Scleroderma, which is an autoimmune disease. Fabry's disease, which is a glycogen storage disease. And eosinophilia, which is an immune response. Metastatic cancer, the cancer cells can infiltrate into the heart cells. That can cause a restrictive cardiomyopathy. And radiation, palliative for cancer, can actually damage the heart. So what we're talking about here is radiation for like a chest tumor. Okay, so you're not going to see any histology slides on step 2 or 3, but what I wanted to show you is what I mean by infiltration. So this is a normal cross-section of heart muscle. So you're normally used to seeing it like this down here, where you're seeing the length of the myocardium, but what we're seeing here is a cross-section. So here are the nuclei that are eosinophilic, and the pink is your muscle. Okay, so in this case, we have a restrictive cardiomyopathy because look at all of this collagen that's forming around the heart cells. So what cause do you think that is? That would be scleroderma. You're getting collagen deposition around the heart cells. How about here? So here we should just see nice, smooth heart cells here. Like right up here, it should be like this, but it should be everywhere across the entire slide. But look at what we've got here. Do you see anything that stands out? Right here. This is a granuloma. And so this is sarcoidosis, the #1 cause in the U.S. Now this is a Prussian blue stain, and you can imagine why we would be doing a Prussian blue stain. You're not going to be shown any slides on step 2 or 3. If you're watching this and you're going to be taking step 1, this is good for you. I want you to know this though, because I want you to have a mental grasp of what's going on in the heart, a visual grasp. So this is Prussian blue stain is a stain for iron. So here we have iron in the heart, and that's going to reduce its ability to either relax or constrict. So let's talk about what restrictive cardiomyopathy has in common to hypertrophic and dilated. So like hypertrophic cardiomyopathy, we have reduced ventricular filling. And that's just because the myocardium is not able to expand as much. We're also going to have somewhat thickened walls. And that could be due to the fibrosis, to the collagen deposition, and so forth. Now, similar to dilated cardiomyopathy, you're going to have pronounced CHF symptoms because we can't get that blood out of the left ventricle and into the systemic circulation. In hypertrophic cardiomyopathy, while we weren't able to fill, we were at least able to get the blood out of the left ventricle. With restrictive cardiomyopathy, just like dilated cardiomyopathy, when that blood gets to the left ventricle, it's kind of stuck. So we're going to have some congestive heart failure symptoms: dyspnea, wheezing, rhonchi, rales, pulmonary edema. We're also going to have signs of right-sided heart failure. You'll see that in dilated cardiomyopathy, and you'll see that in restrictive cardiomyopathy, where you'll have the peripheral edema, increased abdominal girth, ascites, hepatosplenomegaly, increased jugular venous distension, and so forth. You'll also have an S3 heart sound present. Now, what's unique in restrictive cardiomyopathy is that because the muscle of the heart is infiltrated or is damaged, you're not going to be able to conduct electricity very well. That's not the same with dilated cardiomyopathy or hypertrophic cardiomyopathy. In hypertrophic and dilated cardiomyopathy, the problem is not really the heart cell itself. The problem is what's happened with the heart cells in general. They've either reproduced too much or they've dilated too much. With restrictive cardiomyopathy, you've actually had infiltration. And so the heart cells can't conduct electricity properly. And so characteristic of restrictive cardiomyopathy, you're going to have a decreased amplitude on EKG, and that's going to really help you weed this out. And you're also going to have characteristic echocardiography findings. So in a patient where you're suspecting restrictive cardiomyopathy, look back into their history. A lot of times, especially on the USMLE, these patients are going to have a history of sarcoidosis, amyloidosis, hemochromatosis, scleroderma. Those are all things that can cause generalized infiltration of different tissues. Sarcoidosis would be an infiltration of granuloma. Amyloidosis would be an infiltration of amyloid protein. Hemochromatosis would be an infiltration of iron. Scleroderma would be an infiltration of collagen. Metastatic cancer would be an infiltration of tumor cells, and radiation would just cause direct physical damage and healing, which didn't cause the quote-unquote infiltration. The symptoms that you have here are going to be similar to all the other cardiomyopathies: fatigue, dyspnea, shortness of breath, but we're also going to have our right-sided symptoms too: jugular venous distension, peripheral edema, ascites, and hepatosplenomegaly. So really the only thing that helps you distinguish this from, well, if you look at the physical exam, then wheezing, rales, rhonchi, systemic disease, S3 heart sound, murmur, JVD, Kussmaul sign. Really the only thing that differentiates restrictive from dilated cardiomyopathy is the patient's history. Patients with restrictive cardiomyopathy have a history of infiltrative diseases, cancer, radiation. Patients with dilated cardiomyopathy tend to have histories of ischemia, or alcohol, or pregnant. The diagnosis is going to be the exact same way we diagnose all the cardiomyopathies, and that's echocardiography. And it will show rapid diastolic filling, and most certainly, because we have, just like in diastolic heart failure, because we have a problem with the heart cells that can affect the conductive system, we're going to want to look for AFib so we know if we have to treat this patient with digoxin and warfarin. And the EKG will also help us diagnose this patient, will further confirm our diagnosis because we'll see a decreased amplitude because of the decreased ability of the conduction system to proceed. Chest x-ray will be good to assess the extent of pulmonary edema to see if we need to give this patient any short-term diuretics. The treatments are going to be palliative. Unfortunately, restrictive cardiomyopathy does not do well even with long-term treatment. You can give them diuretics to treat the fluid overload, and beta blockers can be useful to increase the filling, which can have some effect on increasing our cardiac output. But really, we're going to have to treat the underlying disorder, which means these patients are going to have a lot of fluid overload correction, and these patients are really going to be candidates for heart transplant. So we're going to talk about pericarditis in a different section, but restrictive cardiomyopathy and constrictive pericarditis, it might be difficult to tell the two names apart even. It's hard to tell the two apart. So the patient's history is what you're going to rely on. And if you ever don't know between the two of these, the best test to distinguish is a cardiac MRI. And in the case of constrictive pericarditis, you'll see pericardial thickening. And that makes sense because this is pericarditis and this is a cardiomyopathy. Okay, so remember that I said that EKG can be something that gives us a hint towards that the patient has restrictive cardiomyopathy, even though the best test to diagnose restrictive cardiomyopathy is your echo. The EKG can give us a hint, it can validate our findings. So let's take a look. Here's a normal EKG, just for reminder's sake. And now here comes a patient. Let's say they are 38, it's a 38-year-old woman with a known history of sarcoidosis based on chest x-ray, and she's coming in because she has swelling of the ankles and increased, she can't fit into her pants properly, and she's got what she feels is a belly full of water. And here's her EKG. So notice the difference. Might be kind of slight, but you really notice it when you look at those precordial leads. At least V3, V4, V5, and V6. Which remember, V3, V4, V5, and V6, we're talking about the ventricular, we're talking about the ones that are closest to the ventricles, the left ventricle. So what really this is it's decreased QRS amplitude. And you can diagnose QRS amplitude in the limb leads 1, 2, and 3 by measuring the QR length as less than 2 millimeters. So this is pretty much, I would say this is about 2 millimeters. So I would definitely consider this low or decreased QRS voltage. Really here V4, V5, V6. If this is what this patient has, and let's say this was a normal EKG, here you got 4 big boxes. Here you hardly have one little box or one big box. So this is definitely decreased QRS voltage. If you see this, now obviously you're not going to get on the USMLE a EKG and be asked, what does this patient have? Because decreased QRS voltage can be from a lot of things. But this is just another thing that you can expect in a patient with restrictive cardiomyopathy. This patient does not appear to have atrial fibrillation, so they won't be needing digoxin and warfarin. Okay, so let's just review the findings on echocardiography. Remember, echocardiography, provided that the patient is stable, will be our first test in diagnosis of this patient. So with hypertrophic cardiomyopathy, you'll see asymmetrically thickened walls, left ventricular more than the right ventricular walls. With hypertrophic obstructive cardiomyopathy, you'll see the same thing as you see in hypertrophic cardiomyopathy, asymmetrically thickened walls, left ventricular more than right ventricular, but also you'll see some kind of an obstruction at the aortic valve, and that obstruction will increase with Valsalva. Dilated cardiomyopathy, you'll see dilated chamber sizes and thinned walls. Restrictive cardiomyopathy, you'll see rapid diastolic filling, and you'll see prominent bilateral atrial dilation. The findings on EKG, in hypertrophic cardiomyopathy, you'll see left ventricular hypertrophy, so high QRS amplitudes in S3 through S6, which are your left-sided precordial leads. With HOCM, it's going to be the same thing as hypertrophic cardiomyopathy. Remember, the only difference between hypertrophic and HOCM is going to be that blockage. With dilated cardiomyopathy, you will see low voltage QRS. You can see sinus tachycardia, AFib, and some ST changes are possible. None of these you're going to diagnose on EKG because none of these EKG is the best next step. So this is just for information in case some of these words get thrown at you. With restrictive cardiomyopathy, you'll see low voltage QRS. Sometimes you can see left bundle branch blocks and some ST changes. Let's see if we saw that on here. If any left bundle branch blocks. It's hard to kind of notice. I don't see any left bundle branch blocks jumping out at me. This might be one right here. This might be a, I don't know. But yeah, I don't see any specific findings like that. But definitely the reduced QRS voltage. Okay, so reviewing how we do this workup here. So the different cardiomyopathies, number one causes, we talked about that. The problem that causes, hypertrophic causes impaired relaxation. HOCM causes impaired relaxation too, but it has, in addition, an aortic outflow obstruction. Dilated is impaired contractility, and restrictive is impaired elasticity. So that's basically impaired relaxation and impaired contraction combined. The most common symptom in hypertrophic is syncope as well as with HOCM, but in HOCM you can also get sudden death. Hypertrophic and HOCM, just like in diastolic heart failure, you're going to hear, in systolic heart failure, you're going to hear S4 heart sounds. With dilated cardiomyopathy, you're going to get dyspnea as the number one presenting sign. S3 heart sounds are also commonly heard. With restrictive cardiomyopathy, you're going to have more severe signs, severe dyspnea, right-sided signs, edema, ascites, and then that Kussmaul sign, which is when the patient breathes in, you would normally expect their jugular vein to become less visible, but in the case of patients with Kussmaul sign, it becomes more visible. The left ventricular size in patients with hypertrophic, it's very reduced because of the increased size of the muscle. Same with HOCM. With dilated, it's very enlarged because it's a dilated ventricle. With restrictive, it's somewhat enlarged, but it's really no change. The ejection fraction for hypertrophic, because we can eject really well, it's going to be normal to increased. With HOCM, same thing. With dilated, it's going to be very low because we've reduced our contractile force. With restrictive, it's going to be relatively normal, but we're not really getting a whole lot of blood in there to begin with. The walls for hypertrophic and HOCM will be thick. For dilated, it'll be thin. For restrictive, it'll be normal. But again, we're talking about not the thickness or thinness of the wall in restrictive. We're talking about the composure of the myocardium. It's infiltrated. For all of these, when we suspect them, the diagnostic modality of choice is echocardiogram. The treatment for hypertrophic cardiomyopathy is beta blockers. The same thing for HOCM, we'll use beta blockers, and particularly these patients are going to want to maintain left ventricular volume. The best ways to do that are hydration, calcium channel blockers can be useful too, and avoid strenuous activity. Keep that heart rate less than 100 at all times. For dilated cardiomyopathy, we want to increase our ability to pump, so we want to reduce the systemic vascular resistance, and we do that with beta blockers, ACE inhibitors, and spironolactone we can add on later on. With restrictive cardiomyopathy, we just treat this symptomatically. We'll use diuretics if the patient becomes volume overloaded. Beta blockers can be good as well. But these patients, you're going to have to manage the underlying cause of the restrictive cardiomyopathy. So if they're pregnant, you're going to want to deliver them. If they're alcoholics, you're going to want to stop that. But most of these patients are going to go on to need heart transplants. And that is it for cardiomyopathies.